Welcome, everyone. Thank you for attending our Ask the Experts series event, Breast Cancer Genetics, where experts discuss risk, screening, and treatment. My name is Juanita Rogers, Vice President of Health Education and Communication here at FORCE, and I will be your host for this event. FORCE stands for Facing Our Risk of Cancer Empowered, and we are a national nonprofit organization devoted to improving the lives of individuals and families facing hereditary cancer. Our community includes many people, including those with the BRCA, ATM, PALB2, CHEK2, PTEN, and other inherited gene mutations, as well as those diagnosed with Lynch syndrome. We accomplish our mission through our support public policy, education, and research programs, and through forging strong partnerships with other organizations. Our programs can be found on our website at facingourrisk.org. And before we get into the details of today, I want to share a brief moment to thank our sponsors for their generous support. Our presenting sponsor is AstraZeneca. Our empowerment sponsors are Lilly and Merck. Our affinity sponsors are Eisai and GSK. And our community sponsors, Foundation Medicine, Pfizer, and Exact Sciences. That's for the interview portion of the program. Dr. Allison Kurian is a medical oncologist at Stanford, and Dr. Liza Wu is a breast and plastic surgeon at Privé Plastic Surgery. Both panelists are also members of FORCE's Scientific Advisory Board. Thank you both for being here. And just a reminder for our attendees, we are not going to be providing medical advice this evening, either during the interview or during any responses that you may hear from our panelists. So always consult with your doctor about any of your medical options. Okay, and we're going to start with questions about breast cancer genetics and risk. And Dr. Kurian, I want to start with you. If you can tell us which genes are linked to a higher risk for breast cancer.
Yeah, absolutely. And thanks for having me, by the way. I'm happy to be here. So when we think about breast cancer genes, sometimes we'll see long lists of things that have been published that maybe have an association with breast cancer, but I want to focus on the list of genes that are widely agreed to be well known to be associated and that we think of as clinically important. And so those genes are BRCA1, BRCA2, ATM, CHEK2, PALB2, TP53, STK11, PTEN, CDH1, BARD1, RAD51C, RAD51D, and NF1. And that can sound like a lot of alphabet soup, but those are the genes, and happy to answer any questions about them later.
Wonderful. And we do have this slide up to kind of help individuals as well as you're listing those out. We know that men have breast tissue as well. Are there any specific genes that you want to speak to as we have this slide up here, or anything to add?
Yeah, absolutely. So male breast cancer is rare. We know it's about 1 in 1,000 for most men, but men with certain inherited gene mutations have a higher risk. The one that's best known is BRCA2, where males who inherit this have about a 6% lifetime risk, so about 6 in 100. There are also risks occasionally with BRCA1, though not as high, and we're beginning to understand there are also some risks with ATM, CHEK2, and PALB2.
This is helpful. And before we go on to the next slide, I want to make sure people know that the QR code does give a little bit more information and expand, just as Dr. Kurian did as well. So there seems to be some confusion, Dr. Kurian, about genetic testing for people with breast cancer. I know that there are guidelines from NCCN about testing such individuals, but in general, what do the guidelines say?
Yeah, you raise a good point, and let me say that I help write some of the guidelines, so they're partly my fault. And again, it's always complicated as we look at new information. And I think it reflects the fact that there's a lot of science going on. More and more evidence is coming out, and that's a good thing. So guidelines change when we learn more. But so at present, what the National Comprehensive Cancer Network guidelines say is that for people with breast cancer, we should offer testing to all men diagnosed with breast cancer at any age. all women diagnosed with breast cancer at age 65 or younger. And many women who are diagnosed at age 65 or older should also be offered testing under certain circumstances that might mean their risk is higher. So if they are of Ashkenazi Jewish ancestry, have triple negative breast cancer, have a family history of breast or ovarian cancer, or could benefit from treatment with a PARP inhibitor, which is particularly effective for people with BRCA1 or BRCA2 mutations.
This is helpful, and Dr. Wu, it makes me want to ask you a question. I know a few years ago, the American Society of Breast Surgeons proposed genetic testing for all people with breast cancer. What are your thoughts on that approach?
So I think there's advantages, and unfortunately, there's also disadvantages of an approach like that. So what are the advantages? You have improved detection of carriers and possibly earlier detection of carriers. There are some mutation carriers that aren't identified under existing guidelines. And if these patients know that there are mutation carriers, it potentially could influence their surgical decisions, whether or not they undergo prophylactic mastectomies or any sort of medications to prophylax against getting cancers, or PARP inhibitor therapies, or the use of radiation, et cetera. It may also increase something called family cascade testing, and that refers to the process where after somebody's identified having a mutation, then you can go ahead and test the family who are at risk, and blood relatives can undergo testing to identify who may have the mutation, because not everybody in the family will have it. So what are the disadvantages? Well, there are people who undergo genetic testing and get a result called VUS, which is a variant of uncertain significance. And what does that mean? Well, it means exactly that. They have identified a mutation in the gene, but they're not quite sure what clinical impact there is. So then what do, right? Do you undergo increased screening? Should you consider prophylactic mastectomies or medication? The relevance is essentially unknown. So what do we do with those types of results? There is healthcare strain testing every single person who is diagnosed with breast cancer, because remember, inherited genetic mutations are responsible for only about 5 to 10% of diagnosed breast cancers. So that means the other 80, 90% of women are getting tested that will not have a positive test for a genetic mutation. And then obviously there's always cost that is included in that. And then finally, if you get tested young and find out that you're a mutation carrier, what does that mean for you when it comes to getting health insurance, right? Is there any discrimination against you because you have this predisposing genetic mutation? Just so everybody knows, there are protections in place, federal protections. There's a law and some states have also additional protections. But essentially, there was this law that was passed. It's called the Genetic Information Non-Discrimination Act, or the GINA, passed in 2008, where there is protection against people who have a known genetic mutation that can cause health issues. And I think, Juanita, I think that if people have questions about that, they can ask later on in the breakout center.
Yes. And thank you for bringing that up. I do want to make sure that people know we do have the slide up, but we also have breakout room 3 with public policy where they'll be able to discuss more. So thank you so much, Dr. Wu. Dr. Kurian, I'm gonna kind of flip back to you and see if you have anything else to add on this, or maybe describe why not just test everyone with breast cancer.
I think it's a great question. And I think we're actually very close. So historically, the deterrents have been cost. It used to be much more expensive than it is now to sequence people. And certainly issues about cost-benefit ratio that were very well outlined by Dr. Wu. I think the other challenges, and I sort of think on a population level, I'm an epidemiologist, and I think in terms of how we manage things, there are challenges in terms of sort of who owns the information and who manages it. So, again, if you test everybody, how is that going to get followed over time? What about when the patient stops seeing her oncologist or her surgeon? Who's in charge of that? So there's some questions about really the healthcare system and how we handle those things. And I think the other piece of that has been a concern that some of the results might be mismanaged. Now, again, we haven't seen a whole lot of evidence of that, but some. What might that mean? That might be that occasionally when we see results like a variant of uncertain significance that Dr. Wu mentioned, there might be cases where someone is treating that like a positive result, which it is not. Fortunately, we're seeing less of that, not super common, but I think these sorts of issues have been raised as potential deterrents to testing everyone without further debate.
Really helpful and something to keep in mind. So as we're having this discussion, please write your questions down and be ready for the breakout rooms for our attendees, because we're going to move forward to the next section, which is breast cancer screening. So Dr. Kurian, when we talk about high-risk screening for breast cancer, what does that entail?
Yeah, so that entails what I think of as our best screening modality for breast cancer, and that is magnetic resonance imaging, or MRI. And MRI is really good for a number of reasons. Now, I'm not a radiologist, so forgive me for being a layperson in this regard, but I think it's really the best test because it is not troubled by breast density, which is a feature that we can see particularly in young women, and certainly also in women of all ages, but especially young women. And it also is a dynamic form of imaging, meaning that because we give contrast, we're allowed, or rather we're able to look not just at shape of a lesion, but also behavior and how it takes up contrast and lets it out again. So it's really a very informative test. And so that is recommended on a yearly basis for people with a higher risk of breast cancer, usually due to any of the gene mutations we talked about before. So it depends, the starting age depends on the level of risk and the gene, and we can talk about that later. But typically we would also add mammograms starting usually at age 30, sometimes at age 40, depending on the gene.
This is helpful, and I want to remind people, because they may see the slide and say it's a lot, we do have access to these slides, so don't worry about writing all of this down. But Dr. Kurian, I noticed that for the MRI column, depending on the gene, some of the guidelines start with recommend or consider. Can you say a few words about that and what we should know?
You are doing a great job, and I commend you at pointing out things in the guidelines that, are certainly things to think about, and how they get done, and all these questions that are very good questions. So what I would say is, I think it is an attempt in the guidelines to make a distinction between levels of risk of genes. And I will say, guidelines are always our best attempt to look at the evidence and come up with something rational to try to fit the level of screening to the level of risk. So in general, with the guidelines, the language of recommend screening with breast MRI is largely reserved for the higher risk gene mutations. And there's a somewhat arbitrary cutoff around 50%. Who made that up? A committee, but you have to go somewhere, right? And so in general, the thinking has been that if we are talking about a risk that includes 50% lifetime risk, that recommend is important, that these people really should be getting breast MRI. When we're looking at gene mutations that confer less than that, so maybe somewhere in the range of double the average risk, like 25-ish% or somewhere around there, that's where consider has come in, because the feeling has been that maybe the risk isn't always high enough that MRI is absolutely required.
Really helpful and probably clearing things up for some of our attendees. Dr. Wu, I want to pause and see if you have anything to add to this.
Yeah, thank you for asking. So I do want to kind of make a little bit of a distinction of kind of like what high risk means. So there's high risk genetic mutations, and then there's just simply being high risk for getting breast cancer, right? So high risk can mean a lot of different things, and I also think it's along a continuum, right? So high risk can mean having a genetic mutation. It could mean having a very strong family history, but maybe not identifiable genetic mutation or a known genetic mutation. I think we've all come across people like that. Personal history of LCIS, prior chest radiation for maybe Hodgkin's lymphoma, or just anybody who's identified as a lifetime risk greater than 20%. Dr. Curran, I'm just, if you could possibly let us know, like, these women who would be considered high risk, so maybe greater than 20%, where do they kind of fall on this chart?
Yeah, I think it's such an interesting question. And I will just say that I think a lot of these thresholds are somewhat arbitrary, right? So on some level, we in the United States have said we think double the average risk, roughly double the average risk is an inflection point at which we should treat people differently in terms of risk. That's, again, a policy decision. So the average woman's risk is about 10 to 12%, right? 1 in 8 or so. So double that, about 20, 25%, right? That's where that comes from. Interestingly enough, if you look in a number of countries, such as those with national health insurance, and I'm thinking of the United Kingdom, I'm thinking of Australia, they pick 3 times. So this is a policy decision, and I just make that point of at what point you want to act differently in terms of screening.
Thank you.
Yes, thank you both. And an aspect that I think may come up in the breakout rooms, but we are going to go on just a little bit to talk a little bit about the effects of breast density on screening. So for someone who might already be at high risk, how much of an impact does the breast density have for that high risk individual? Dr. Curran, I'll start with you.
Yeah, it's an excellent question. And I will say that I think breast density in some ways is still a bit mysterious. That what is this really? Again, I'm not a radiologist, but so there are sort of a few different things. And the way I think about breast density, and I'm sure you have resources there, is that normally you want a mammogram to be a nice dark gray color so that cancers show up white on a dark gray background. When the breast tissue is dense, it looks more kind of white and clumpy. And you can imagine that it's hard to see a white cancer behind all that. I always joke it's like a polar bear in a snowstorm, but those are my stupid jokes. But at any rate, it's harder to see. And so I think the main problem with density is that it reduces the sensitivity, the ability to find cancers because of that. There's a separate issue, which is that it seems in and of itself to be associated with higher risk. So it's not just that it's masking. It may in itself be a risk factor that has to do with hormonal exposure and other things. There's certainly a genetic component in terms of heritability. There's certainly an age component and a hormonal one in terms of if you give someone medications like tamoxifen, you will usually see a reduction in density. So just a few basics about it.
Yes, and it's complex. So we did put up some QR codes to share a little bit more about those screening options for individuals, as well as some breast density information, because there's more to discuss and know for our attendees in the breakout rooms and on these resources. But I know that we've heard for mutation carriers who are worried about radiation and mammograms. Are there any mutations that cause the high sensitivity to radiation, or what should people in our community know?
So it's a great question. And there have been sort of historically worry about all of them, right? So there was initially a lot of worry about BRCA1 and BRCA2 and mammograms. And that really, fortunately, hasn't seemed to pan out very much. We haven't seen evidence that there is danger from diagnostic mammogram for people with BRCA mutations or most others. And the only one where we worry a little bit more is TP53 or Li-Fraumeni syndrome. And again, I think it's hard to prove danger there from diagnostic imaging, so a mammogram or a chest x-ray. What we have seen in some studies is that people who get higher dose therapeutic radiation, so for example, radiation to treat a breast cancer, to treat something else, that may be more likely to induce a cancer in people with TP53. But so in terms of imaging, we typically try to avoid X-rays and other kinds of imaging with any radiation in people with Li-Fraumeni syndrome with these TP53 mutations. I will say that for everyone, it's age specific. So the breast area seems to be more sensitive when one is in one's teens or 20s. And thus we usually don't do mammogram in anyone if we can avoid it below age 30.
This is helpful. No, that's really great to know. But besides the mammograms and even MRIs, are there any other new or emerging breast screening options that would be helpful for our community to know?
Yeah, so I think the one that at least I'm seeing used most and where I think the data are really interesting is contrast enhanced mammogram. And so what is that? Many of you or many of the audience who may have had MRIs know that this is a test where you get an IV put in, you get gadolinium contrast, then you go in the machine where you have to lie on your stomach for a long time and, it's noisy and things like that. And the contrast enhanced mammogram is what I think of as kind of an easier version of that. So with that one, it is a mammogram. So the usual x-ray of the breast that you get 2 views and they do some compression, they one way and then the other way in terms of the mammogram. But the difference here is that you get an IV placed before you do that. They do give you contrast. It is the kind of contrast you get for CT scans, not for MRIs. So it's a different kind, but they put in the IV, they put in the contrast, and then you get your regular mammogram. And that's pretty much it. How does that work for a person? Basically, it gives you some of the benefits of MRI. So you're able to see functional things like how fast does something take up contrast, which sometimes can help you know if it's benign or malignant. And you also have a bit of a easier time dealing with density overall. And so again, the data are coming out, but I would say the studies we have suggest that contrast enhanced mammogram is probably almost as good as MRI in a number of situations. Right now, I still don't think we want to think of it as a replacement of MRI for women at high risk who need it.
It's helpful. Thank you. And in thinking of some other changes or what may be ready, we do hear a lot about multi-cancer detection tests. What are these? Are they ready for prime time? Is there a role for them in the high-risk early breast cancer detection community?
So many good questions. So the multi-cancer early detection tests are really interesting. And the idea here is that a blood test is done and it is looking for shedding of cancer-associated DNA into the bloodstream. And the idea is that there then would be the ability to say, we think this kind of DNA is most likely to be from, you name it, but we could just say an ovarian cancer. They have a system of trying to identify which is most likely. And if that were the case, then the person might be able to go on and get some screening for that, potentially whole body MRI in some cases, potentially more targeted screening. So I think those tests are really interesting. They are in various kinds of studies in various settings. And what I will say is that I do not think they're ready for prime time. I think joining a trial that is looking at these tests is a great option for people, but I would not order them outside of a clinical trial. And I would say, particularly for people with inherited mutations, they really haven't been studied very well. And so I would hesitate to do it outside of a clinical trial, but I think they're exciting.
That's helpful. And we are going to share a couple of studies. I do want to point out that there are some research opportunities where Force is partnering with the Wisdom Study, which is a large clinical trial, and it's enrolling women who have not had genetic testing yet. So the study allows women to decide if they wish to learn their risk of breast cancer. It offers the genetic testing, and once they learn about their risk, accessing that screening based on their level of risk. So here's a QR code where individuals can bookmark this information and read up a little bit more. And before we move on to the next section, Force does have a study open at this point, and you'll see the information here, where we're looking for individuals with autism who have been diagnosed or who are at high risk for breast cancer to complete a brief screening survey. And those who qualify will be invited to take a short part 2 about their experiences, which is really helpful. And the goal is really to just develop new useful resources for high-risk individuals who are autistic. And so we want to hear from you. And if that aligns with you or anyone you may know, you'll want to scan that QR code. So thank you, Dr. Curry. And we're going to leave this up for a second and then move on to the next section. All right, and so we will turn to breast cancer risk reduction. And I know that, as far as lowering breast cancer risk, what medication, Dr. Kurian, can lower breast cancer risk? And also, should women with mutations consider taking medications to lower their risk?
Yeah, this is another great topic. And what I will say is that there is a long history of studying this question. The first trial of breast cancer risk-reducing medication was with tamoxifen, which, as people may know, is a medication used to treat breast cancer that is hormone receptor positive, and it works by interacting with the estrogen receptor on breast cells and other cells in the body. And so that was a trial back, I believe it reported out in the late 90s, and it showed that there was a significant benefit, a reduction in risk of developing breast cancer if you took tamoxifen for 5 years. Now, at the time, this was before people were routinely tested for BRCA1 and 2. BRCA1 and 2 were only discovered in the mid-90s, so when the trial was enrolling, people didn't have the opportunity to be tested. And looking back, later, people did do some testing in that trial to see if there were people with BRCA1 and 2 mutations, and there were, but not very many. So it was hard to sort of say much about benefit of tamoxifen specifically in carriers. But I will say that in women with a similar range of risks, so double the average or higher, that kind of number, tamoxifen has been shown in that study and other studies to reduce risk by quite a lot. So by about 1/3 to 1/2 of risk reduction in general. And in terms of durability, there's evidence to suggest that that lasts around 15 to 20 years in the studies that have been done so far. And it doesn't mean for sure it would be gone after that. It's just that the studies haven't followed people out longer or haven't reported out longer than that yet. So that's the upshot, is that this can be a good option for people. That being said, nothing comes for free, right, in terms of side effects. And so the concern has been, what about the risks here? There are some risks with tamoxifen. There are common side effects that are sort of in the annoying category. So hot flashes, which for some women are no big deal. Other women are a really big deal, and it depends. And then there are side effects that are unusual, but more serious. So rare, but some evidence of side effects of things like cancer of the uterus, more common if people are postmenopausal. We don't think specifically more common in people with genetic mutations, but just something that we are worried about. Again, low number, single digits, low single digits, all of those kinds of things, but something that we keep in mind. And then some increase in risk of blood clots. And that's about the same magnitude of risk as with birth control pills. So you get a sense of that. They're rare events, but understandably, they worry people who say, I don't even have cancer. Why would I want to risk that? So one new development that I think is really promising is that there was a study reported out a few years ago of using lower dose tamoxifen. So this was a study done out of Italy, and they used 1/4 of the standard dose. So instead of the 20 milligram dose, they used a 5 milligram dose. And they saw a lot of benefit to that. Now, what they were looking at there was women at high risk, usually because they either had something like ductal carcinoma in situ, so an early non-invasive cancer, or features that we heard a little bit about from before from Dr. Wu, things like hyperplasia of the breast, things like that, that put them at more risk. But so in those women, they did see, again, about a reduction by 1/2 of their risk of developing breast cancer. They did not see blood clots, and they did not see uterine cancer. So I think it's worth knowing that low dose TAM may be very well tolerated and looks quite effective. The data on premenopausal women are less good. So I think really it's mostly postmenopausal women where I would go for the lower dose. And I should say they don't have data specifically in people with mutations.
This is helpful, and I do want to plug you and remind attendees that you are going to be in a breakout if individuals have more questions, and especially on chemo prevention. And so at Force, we've promoted several studies, I would say, for breast cancer prevention, vaccines, medications that are known to lower risk, although I don't know if any are still enrolling. Have you heard anything new about studies? Is there anything coming down the pike that our community should be aware of?
Yeah, so this is such an important area. I think there's been some really nice vaccine work. I think of some studies at the Vassar Center, which is really leading the way in so many ways. It's just an amazing center for BRCA-associated research. And we recently heard some presentations on this at the American Society of Clinical Oncology meeting, mostly that in early work, these vaccines are safe, tolerable, all those really important things to move forward. I'm not aware of effectiveness data yet, of efficacy data, and I think we're waiting for that, but safe is the first step, right? So that's really important. I think in terms of other prevention studies and where we are, right, there's a lot of interest in different things. One area that is, I would say, sort of eagerly awaited is the ability of studies to look at the PARP inhibitors. So the PARP inhibitors I can talk about more if helpful, but are really exciting targeted drugs, and FORCE has been really important in helping to enroll for key clinical trials that are more effective for people with BRCA and probably also PALB2 gene mutations with a number of different cancers. So with them being really effective for treatment, how about prevention? And so I think those trials are being developed. It's been a little tricky to figure out how best to study that question, but I think after years of wanting this, we are getting closer.
That helps. And I think that question or those questions about PARPs for prevention may come up. So be ready for
Right.
those.
I'll do my best.
I know that many women in the FORCE community choose mastectomy for risk reduction. And so I'm going to switch Dr. Wu just really quickly because I want to hear, Dr. Wu, do you have any tips or suggestions for women who are trying to choose between surgery or surveillance?
Yes, it's an extremely personal and a very, very complex decision. And, there's not one good answer for everybody, and it really just depends. So it depends on factors such as, genetics, age, family history, personal values, reproductive plans, and basically your tolerance for uncertainty. So the two main paths are prophylactic mastectomy versus surveillance. So with prophylactic mastectomy, most people don't realize, but if you have prophylactic mastectomies, it actually doesn't take your risks down to zero, right? It reduces your risk about, I say, down to single digits, so 95%. But not 100%. Luckily, we have advanced our reconstructive abilities so that if someone does choose to have prophylactic mastectomies, they can undergo reconstruction, which then minimizes kind of like the postoperative deformity. But there are permanent changes to your body that you undergo with prophylactic mastectomies. So if you undergo prophylactic mastectomies, it essentially eliminates your need for screening. Okay, it doesn't mean you're never going to get another MRI. It doesn't mean that you're never going to get another mammogram or an ultrasound, but it does mean typically that you will not have to have the Q6 month or every year annual screening for breast cancer. And I say typically. So it's not without its downsides, though. All right. It impacts your body image. For some women, it may impact their sexuality if they are very connected to their breasts and rely on breast sensation, because with mastectomies, you typically lose the sensation in your breasts. It's irreversible. You're never going to be able to reverse that decision to remove your breast. And again, it results in numbness and potentially even chronic pain for some women undergoing prophylactic mastectomy. So not a very easy or light decision to make. On the other hand, if you choose not to undergo prophylactic mastectomies, you will likely have to continue to undergo enhanced surveillance for the rest of your life, like truly for the rest of your life. So surveillance, it's not preventative, right? It just is for early detection, right? So it doesn't decrease your risk for breast cancer. It just in hopes of catching it early when it's very treatable. But there's no surgery time, there's no recovery time. You maintain your anatomy and your breast tissue and sensation. But again, it doesn't prevent cancer like prophylactic mastectomies.
That's helpful. And we do have some resources up, and I'm sure you're already aware there's likely going to be questions as people kind of bring up these QR codes and have these resources available when they're ready to speak with you in the breakout rooms. But FORCE has followed the research on breast implant-associated lymphomas. And so, Dr. Wu, I want to know if you could tell us a little bit more about that, what it is, what should women in the FORCE community know about this?
Okay, so what Juanita is referring to is something called breast implant associated anaplastic large cell lymphoma. It is a cancer that is associated with breast implants. It is not a breast cancer. It's actually a lymphoma, which is a different type of cancer. Most people think of it as like a blood cancer, not a solid sort of cancer. But what it happens is it develops in the tissues or the capsule around an implant. Now, it doesn't mean that the implant causes the cancer. If the two are just, there's an association, and they believe that's associated with a certain type of implant, which is a textured implant, all right? It is essentially a T cell non-Hodgkin's lymphoma. So they believe that what happens is this texturing around an implant can set up a milieu where there's chronic inflammation, potentially infection, irritation, inflammation, and then there is a little bit of a component of genetic susceptibility as well. Now, thankfully, this breast implant associated lymphoma is very rare. Okay, very rare. You may have heard approximately, it's been quite a few years now where they actually pulled some, they were the nitrile or allergen textured implants off the market. If you have one of those textured implants, the risk of developing breast implant associated anaplastic large cell lymphoma was about 1 in 2,600. So again, very, very rare. And then if you have textured implants from either Mentor or Sientra, which are the two other main implant companies that have textured implants, your risk is even lower than that. So 1 in 6,500, 1 in 20,000. So again, very rare. What are the symptoms? What are the things that you have to look for if you happen to have one of these types of implants or have had in the past? You may not currently have them, but if you've had them in the past, unfortunately, you are at risk. So what you're looking for is changes to your breast, such as swelling, a palpable mass. Very rarely, people may have more kind of constitutional symptoms, such as like a rash, swollen lymph nodes, even fever, night sweats, those sorts of things. But those are less likely sort of symptoms. So how do you diagnose it? Well, you need to see your doctor first and foremost. See your plastic surgeon, see your breast surgeon, see your medical oncologist, see somebody. If cosmetic augmentation patients can get it as well, right? Not just for breast cancer. You see them, and typically diagnosis is done through an MRI and taking the fluid that collects around the implant and sending it to cytology so they can look at it and see if they can identify certain markers that the anaplastic large cell lymphoma puts out in the fluid. How do you treat it? Thankfully, if caught early, it's very treatable, right? What happens, surgery, we take out the implant, and then we take out the tissue surrounding the implant where the cancer lies. And sometimes that's completely curative. And occasionally, patients may have to undergo more treatment, adjuvant treatment, if it's gone beyond that capsule. So people who currently have textured implants, there's actually no recommendation for you to go to your plastic surgeon or surgeon and ask them to be removed. All right. The FDA doesn't recommend it. Most people do not. Your healthcare professionals are not telling you that you have to have these removed if you have them. What you need to have is a heightened awareness and follow along with your plastic surgeon. And if you have any changes, to be sure to visit your healthcare provider.
Really helpful. And I'll have another question for you, Dr. Wu, but Dr. Kurian, recently there was an article that suggested that women with inherited mutations who have breast implants may be more likely to develop this implant-associated lymphoma. Should our community specifically be concerned?
I don't think the community should be especially concerned. I think the results are early, they're suggestive, they are not definitive. I wouldn't recommend doing anything differently. I agree completely with Dr. Wu, who is much more expert in this than I in terms of management, for sure. But I would just say anything that you notice, any change should be promptly evaluated and brought to medical attention.
Very helpful. And up on the screen is our X-ray review of this, examining the relevance of articles for you. For those who are not familiar, you may want to utilize your phone to get the QR code and bring it up. But again, Dr. Kurian and Dr. Wu are sharing their expert insights, which is really helpful. Thank you. And Dr. Wu, is there anything else new related to breast surgery or reconstruction that our community should be aware of?
Yeah, there's a lot of really exciting things that we have started or are on the horizon. And I'm happy to speak more about these in the breakout session. But there's a lot of questions about nerve sparing mastectomy or nerve reconstruction and breast reconstruction. We can talk about direct to implant reconstruction, the use of scaffolds. We can talk about perforator flaps, the different kinds that have come into play so that you can recreate a breast not using an implant. And you know, the new implants and the new technology we have with implants that are really fresh in the market recently, like the larger size Mentor implants up to, I think, up to 1,500 cc's, and then the new implant company Motiva that has been in use for many years overseas, but recently FDA approved for cosmetic use here and hopefully for reconstruction very soon.
Really helpful. And we do also have some resources up. I'm sure there may be some questions, especially about DTI use scaffolds. So we look forward to having you in our breakout session. But let's talk a little bit about breast surgery in men. And Dr. Kurian, I'm wondering if you could tell us more about men with mutations and their consideration for bilateral mastectomies.
Right. So certainly, you know, we know that there is higher risk among men with mutations. And I think of BRCA2 is probably the one with the highest numerical risk. So our estimate is, you know, around 6% lifetime risk. So to put that in context, the average woman in the United States without high risk or without a genetic mutation has about a 12% lifetime risk. So for men with BRCA2, their risk is way higher than the average man, but it's only half that of the average woman. So I think of it that way. And that's one of the reasons we don't typically recommend preventive mastectomy to men. There's a 94% chance they won't get breast cancer, just as we don't recommend prophylactic mastectomy for women at average risk.
That's helpful and puts it into context. And so as far as surgical aspect, Dr. Wu, can men have reconstruction after mastectomy?
Yes, men can have reconstruction after mastectomy. Typically, it has to do with whether or not they had their nipple areolar complex removed and whether or not they want to undergo reconstruction of that nipple areolar complex. And then if there are some contour issues that are bothersome, we can consider things like fat grafting.
Very helpful and promising, actually. So I'm sure you'll get additional questions in the breakout, but we're going to move on to our section on breast cancer treatment. First, we'll talk a little bit about diagnosis. And so, Dr. Wu, I wanted to know what happens when someone has an abnormal mammogram or MRI, and how do you find out if they actually have breast cancer?
So typically what happens is either the woman or man, the patient, will palpate a mass. Perhaps their healthcare provider will palpate one during their exam, or they find one on screening mammogram is the typical way that that it starts. That will then prompt a biopsy, confirming the diagnosis of breast cancer. And then after that, what happens is a series of steps in which we initiate your treatment plan. This treatment plan is put together by a multidisciplinary group of people. It's not just one person. And I think sometimes this is amazing. This is great because you have a whole team that's helping you through this process. But in the same breath, it can get very confusing. So again, a great thing. It's a great thing, but it can be very confusing because you're going to meet, most likely, you're going to have your radiologist that is going to identify the cancer and potentially biopsy it. You're going to meet with a surgical oncologist who will remove the cancer. You will likely meet with a medical oncologist who will make further recommendations for the treatment of whatever it is that they have found. You potentially will also meet with a radiation oncologist who will treat the breast with radiation should you require it. You may indeed also meet with a plastic surgeon if that is desired or recommended. And then there's a whole host of other people as well, physical therapists, nutritionist. Again, there's a whole team for you to meet with as you go through the process that can help you along.
And so as we're thinking about kind of continuing on through the process, Dr. Kurian, as we think about early stage breast cancer treatment, I know that when people hear that they have cancer, they often want to have surgery as soon as possible to remove it. But are there ever other times where it's just better to wait until after treatment to have surgery? What more can you say about this?
Yeah, it's a great point. And of course, anyone who would hear those words would think, I want it gone yesterday, right? So completely normal and understandable to say that. I think there are a few settings in which there are data that it's better to do something medical before we do something surgical. And so that usually is giving chemotherapy with or without other medications before. The settings in which there is a good reason to do that there's good proof that it improves survival are if you have a cancer that is triple negative, ER, PR, and HER2 all negative, or a cancer that is HER2 positive. So either ER positive or ER negative, but HER2 positive. And it's not for all of those cancers. It wouldn't be if it was a really small one, but typically we're talking about stage 2 or bigger, and we can talk about staging, but generally in that frame, where what's been shown is that if you give chemotherapy, or again, sometimes chemotherapy and targeted therapy first, you then have the opportunity when you go to surgery to see how well it worked. And so what would be optimal would be if a person has what we call a pathologic complete response. So you go to surgery and the cancer is all gone. That's fantastic. And if that's the case, that tends to portend very well for survival, and usually not much difference in treatment would be needed afterward. However, sometimes we see that there is less than a pathologic complete response. There is cancer left behind. And what studies have shown us is that you then get a chance to choose again. And so basically, when that is found, there's evidence that if you switch drugs, so in each of these cases, triple negative and HER2 positive, if you switch to a different drug, those patients had better survival. So for those patients with larger triple negative or HER2 positive breast cancer, it often is a good idea to have that opportunity to see how the first treatment worked by doing it before surgery, and then choose again. Usually with ER positive, HER2 negative, which is the most common kind of cancer, usually there isn't a strong reason that we need to do that. We don't at the moment have proof that it improves survival that way. But I think data are coming on a few scenarios where we may see more.
Exactly. And I know that there have been a couple of significant advances in the targeted and immunotherapies for early stage
That's right.
breast cancer. Is there more that you want to
Right.
share here?
Yeah, so I think it's really interesting, and I will comment because some people may be aware of it, on a trial that was done in people with BRCA mutations. So the partner trial, this was quite a small study, so I don't think it's definitive because it was quite a small study, but it was interesting in terms of doing PARP inhibitors plus chemotherapy neoadjuvantly or before surgery in people with BRCA mutations. And so there they didn't see a big change in the pathologic complete response, but they did see a benefit in terms of survival. So that certainly gets our attention. I think, again, I wouldn't run away with saying we have to do that yet, in part because we know that giving PARP inhibitors after surgery in that setting also improves survival. So I think there are a lot of unanswered questions. PARP inhibitors are often a good idea if there's a BRCA mutation, at any point in the care. So I would put that in that light. And so that's just my specific comment there about that. Is it helpful to talk about some of the other new agents, or what would be most?
Yeah, I think it'd be really helpful to know about
Hmm.
some of the indications in early breast cancer as far as pembro, olaparib,
Sure.
anything that
Sure.
you want to share.
Yeah, I'll be happy to do that. So pembrolizumab is one of a group of drugs called immune checkpoint inhibitors. And so what these drugs do is basically to turn on the immune system. So for reasons we don't fully understand, when people have cancer, you'd think the immune system would get rid of it, right? The way we get rid of, infections. But unfortunately, cancers generally have had a way of turning off or kind of hiding from the immune system. And so what pembrolizumab and other drugs like that do is they can actually help to turn our T cells, our immune cells back on to fight the cancer. And it's pretty amazing. So when these drugs came out, 10 or so years ago, we saw them working on cancers like melanoma, brain cancer, where we just had nothing, and all of a sudden people were living who had died before. And it was an amazing thing. And so we are starting to see this move into other cancer settings. And one of them where they've been quite powerful has been in triple negative breast cancer. So again, triple negative breast cancer, one that is common in people or more common in people with BRCA1 and other gene mutations, there now is evidence that if you give people pembrolizumab before, again, in this neoadjuvant setting, so before you go to surgery, they then can have better survival in that setting. So things are being worked out of exactly when to give it and the right circumstances, but it is really standard of care if you have a triple negative breast cancer of stage 2 or higher, that you would be considered for getting this immune therapy upfront and potentially later, depending on what's going on. And for people with metastatic breast cancer, also, these immune checkpoint inhibitors are important. I spoke a bit about the PARP inhibitors. Olaparib is one of them.
Right.
It is a really important drug to give after surgery in some cases for early stage breast cancer, saves lives. Also important in terms of later stage breast cancer. Quickly, because I don't want to go on too long, the CDK4/6 inhibitors are interesting drugs. I think of them as cell cycle inhibitors. So they're drugs that help to slow down or kill rapidly proliferating cells. And they have a synergistic effect together with anti-hormone therapy. So you will see patients who are getting things like aromatase inhibitors and who then will have a CDK4/6 inhibitor added. And with early stage breast cancer, again, usually stage 2 or 3 ER/PR positive breast cancer, we're talking about having one of these added at the beginning of the period of taking an aromatase inhibitor for 2 to 3 years.
It's actually really helpful. And we're going to mention these QR codes, but there's clinical trials we want to get to for people to share, because I want to remind everyone that there are clinical trials enrolling people with early stage breast cancer, and 2 that we feature on the Force website are shown here. We want to make sure that this information gets to you. So we encourage you to visit our website, visit clinicaltrials.gov, talk with your doctor about any clinical trial options that may be available to you. Okay, and Dr. Kurian, I'm going to have another question for you because we want to talk about the advanced stage and metastatic breast cancer. I know that there have been some recent advances in the treatment. So let's start with HER2 low, HER2 ultra low.
Yeah.
Seem to be somewhat new biomarkers. So yes, please tell us more.
Yeah. So I think it's really interesting. And what I'll say is the whole idea of HER2 low is not really a new thing. It's just a different way of looking at something we measured already. And so HER2 is this biomarker or sort of an aggressiveness gene that is present in, I always say around, 1 in 5 to 1 in 4 breast cancers. And when it's there, it tends to be really important and a driver of tumor activity and growth. And so we learned years ago that targeting that biomarker or that gene overexpression with antibodies was really effective. Those are drugs like Herceptin, and they have saved a lot of lives. So that's what we knew. But so what we thought was that you had to have really strong expression of HER2 in the tumor or else it wouldn't work. And so what we used to do was measure it on a scale of basically 0 to 3. And only if you had 3, so high level of expression, would we think it would be useful to give you one of these drugs. However, in recent years, it's pretty interesting. People started saying, well, wait, what if we thought about people with a 1 or a 2? Could they also benefit? And so what's been learned, particularly with a really effective drug that is an antibody with a toxin attached to it. So the antibody is that Herceptin antibody to HER2 with a toxin on the back. What they found is that people who previously would have been called HER2 negative with a score of 1 or 2, we now would call them HER2 low, or in some cases ultra low, and they actually benefit from that effective therapy. So people we would have called triple negative in the past have gotten really great results from this new HER2 targeted therapy. So it's sort of remade the field in terms of
Mhm.
thinking about, how low can you go, right? It's such a sort of stupid comment, but, what about HER2 zero, right? So again, there's been exploration of maybe there are new ways we could be measuring that category of HER2 zero, and we might see some people who benefit. So I think it's an exciting frontier.
Absolutely. And for metastatic breast cancer, what are the targeted therapy treatments that people on the call should be aware of? Any new targeted agents or clinical trials,
Yeah.
and information, especially beyond BRCA1 or BRCA2?
Absolutely. So just commenting that quickly, BRCA1, BRCA2, PALB2, in the metastatic setting, we always want to think about PARP inhibitors because they are especially effective. So we never want that to be missed. But with that being said, certainly for people with other gene mutations or for people without gene mutations, there are a number of other new and I think exciting agents that just help us treat people for longer and better with metastatic breast cancer and make people live longer. So all of that is great. So again, there are a handful. One that has been important recently is a drug called capivasertib. It's called TrueCap is its name. Don't ask me who makes up these names. Honestly, they're like crazy and impossible, but whatever. So TrueCap or capivasertib. And that targets a pathway called the P10 AKT and then PI3K or PIK3CA pathway. And so people with acquired mutations in any of those genes in their tumor can have a good response. But I think there's also been a lot of interest in people who carry an inherited mutation in P10. So we call that Cowden syndrome. It's pretty unusual. But there are people who have it and have a high risk of breast cancer. And so there's been a lot of interest in, could that be an especially good drug for people with metastatic breast cancer who have an inherited P10 gene mutation? I will say I don't think there are a whole lot of data yet, just because it's a rare syndrome, but it's certainly something that we would think about in those cases.
Absolutely. And I know that we're going to get some questions. And so we want to make sure that we're getting
Yeah,
this information to people. But how about you just explain a little bit about biomarker testing,
for
especially in
sure.
people with advanced breast cancer?
Absolutely. So just to say sort of what is a biomarker, and my apologies that everyone probably knows this, but the whole idea is years ago, back when I started in oncology, certainly, and before that, we sort of treated everybody the same in some ways. I mean, we knew about ER and PR. We were just starting with HER2. I mean, just as an example, when I started training, it was that you had to give chemotherapy to everybody with a tumor bigger than a centimeter. That is not what we do anymore at all because there have been big advances and we've spared a lot of people chemo and given it to people who need it. So the idea is really by genetics, by other molecular techniques, we can characterize a tumor better and really personalize the care in terms of saying what genetic abnormalities are here in the tumor. Some of them will be things the person was born with, so an inherited mutation. Most of them aren't. Most of them are things that got acquired when the tumor was developing. So the upshot is we're just getting better and better at sequencing tumors genetically, at other ways of characterizing them and saying, oh, look, there's a mutation that we can use as an opportunity for a different therapy. So that's really where we mostly are. And so we may do repeat sequencing. So for example, if somebody is diagnosed with metastatic disease, we will biopsy it, we will sequence it, we might act on what we see. Let's say at some point that cancer grows, we may rebiopsy it and do it again because cancers evolve. And sometimes it may have acquired a new mutation that we can exploit to treat the tumor. And sometimes we even will do it not from a rebiopsy, but from a blood test, which can begin to look for those biomarkers circulating in the blood, but coming from the tumor. So that's really the biomarker area right now.
It's really helpful. And part of being able to advance is having those clinical trials so that we can get more information. And so Dr. Kurian, I know that there was some information you were going to share, but I at least want to just kind of let people know that they have this QR code and perhaps they can ask a few more questions during the breakout room with you. But we just want to let people know that EvoPAR BR01 study, fast and furious, if there was a way that you wanted to describe, we are going to put up the eligibility and then we'll probably share a little bit more about some clinical trials.
Yeah, so one of the amazing things, there's so many great things that Force does, but truly the contribution to the new science that directly benefits people in this community is amazing. And it's one of the things I think FORCE should be the most proud of. So at any rate, really key to remember this is the only way we move forward. And it's wonderful that people are willing to do these trials and participate in these trials most of all. So this one is, to my understanding, and I am not involved in it, so there are others who are more expert, but basically a study that enrolls people with both BRCA1 and 2 and PALB2 mutations with hormone receptor positive breast cancer, and is looking at a combination of one of the new PARP1 inhibitors. So the idea is being a bit more selective and perhaps then being more effective and less toxic, so fewer side effects. And then together with an anti-hormonal medication. So all these questions of, can you do better by combining? Can you be more selective? Can you be more effective? And I think really important research to do and participate in.
Thank you. And there are a few clinical trials that we want to share here. And as a reminder for our attendees, we do share the slides. The resources are available to you because we're going to kind of click through and get to our closing thoughts for our attendees. But please know that there are clinical trials for advanced cancers, including breast. And that we share this information within the resources that you have. You can utilize your phone to get to the QR code, and you're seeing those kind of come up on your screen here. And just wanting to make sure that individuals know that they can visit our FORCE website, find studies, reach out to us to ask questions, get your questions answered, and find more information that may be appropriate for you as far as a clinical trial related to breast cancer screening, prevention, or treatment. This has been incredibly informative. I learned some things for sure, but I did want to ask our panelists, our experts, to weigh in just a little bit. How do we get more people to have genetic testing, and also any closing thoughts that you want to share? Dr. Kurian, I'll start with you.
Yeah, this is one of my obsessions. So, I have many, but, we can't help if we don't know the risk, right? So I think it's so important. And there are many controversies about, should we just test everybody in the world? And, we're not there. Our current strategy in the US and in many countries has been basically you start by finding gene mutations in somebody who has a cancer, because that's where it's likely to be. But then a key part of that is something called cascade testing, where basically if somebody has a cancer and they have a genetic mutation, we really need to have that testing cascade out to their relatives, first-degree relatives, second-degree relatives, and onward, so that in that family, we can find people who are at higher risk before cancer happens and then get in there and do a better job of preventing. We are not good at this in the United States, also in other places, but particularly with the fragmentation of our healthcare system. In general, we have estimated that maybe about a third or fewer of people ever get that cascade testing, when it's always a personal choice, of course, but we would expect it to be much higher than that. So we have recently started a program at Stanford together with wonderful partners from all places called PROACT, where we are actually going to be running a clinical trial soon of an online approach to being able to reach out to relatives, help relatives get very focused education about risks and benefits, and then get low cost or free testing. So that's where we're trying to go with that.
Wonderful. Thank you. And Dr. Wu, how do we get more people to have genetic testing, and any closing thoughts you want to share?
Yes, I think that education is key. Understand that, that the genetic mutation testing is out there and available to you. Hopefully we get reduced barriers to insurance coverage, reduce discrimination, and again, education. And I think things such as Dr. Kurian's study, getting these people enrolled in databases so that we can follow them, follow their family members, see, and then be able to exact management and treatment based on what we find out and what we learn about these genetic mutations is so key, so key. And then, of course, what FORCE does with the education and outreach, and letting people know what resources are out there for them.
Very helpful. Thank you, Dr. Wu. Wow, so this was incredibly insightful, lots of information. We are going to get to the breakout rooms in just a moment, but if you can please complete our feedback survey on tonight's webinar, that would be helpful. I want to thank our incredible panelists who are going to stick around. Again, we have our breakout rooms. So we'll keep up this QR code for just a second, and please remember that we do have the resources available to you.